What makes for a surgeon? As you understand, when we start doing our MBBS or this thing post graduation, not everybody can actually walk into the operation theater and have an appetite for that. Some people make excellent physicians, some people make excellent diagnosticians, some other people make excellent radiation therapists. Now, I do not have an appetite to become a radiation oncologist or a physician, because the qualities which are really needed for that is totally different. What does a surgeon really need? You need to have a high degree of manual dexterity, good and hand-eye coordination, excellent vision and visuospatial awareness, at least a correctable vision. You can't really be weak in your eye and be an excellent surgeon. That's going to be difficult. Good organizational ability to lead your team, because you always have a couple of surgical assistants, the nurses, the anesthetists, everybody, and you're the captain of the ship. And quite often it's your ability which will either sink or float the ship. Excellent communication skills to deal with a wide variety of colleagues, patients, and their families, ability to explain, ability to open the diagnosis to them, take them through the diagrammatic representation of what you are actually targeting to do, and then recapitulate the whole thing when the surgery is done. A good emotional resilience. You will go through an ups and downs tremendously. The patient does have an effect of the disease. He will have the effect of the surgery that you're going to do. And you need to take it with a calm temperament and an ability to work well under pressure. Very important. Patient is bleeding on the table. If you start throwing instruments around, you're not going to make a good surgeon at all. So physical stamina also to cope with the demands of surgery. In fact, some of the senior surgical writers mention that you should actually have a physical trainer if you want to really become a good surgeon. So I think that's taking it to too much of a this thing, but I'm sure Max will definitely put somebody for Harit, considering that he's a star champion there. But suffice it to say that you need to be physically fit and the ability to lead and manage a team. Where do we really go? Why is it thoracic surgery, the thoracic cancers are important? Let's just take a view at this Globocan 2018 India fact sheet. Out of 11,57,000 new cancer patients in 2018, 10.81% were thoracic cancers, and out of which practically 6% were lung cancers. So that is the kind of numbers and this number is going to increase practically almost 2 to 3 times. In our penchant to become developed country, please remember that we are also importing their diseases. So 67,795 new cancer cases 2 years back, and at the same year, 63,000 died. These are not the same patient who were diagnosed, but it means that you're dealing with an enemy which practically takes no prisoners. So when you are doing something like this, you have to have a certain amount of proper attitude. And why is it really important? India is already on the way to take over the position of being the most populous country. Probably, I think this year or next year, we are going to beat China as far as being very populous, not a record that we should be very proud about. And 3 of the 6 top causes of death are from respiratory disease. Cancer lung is rising very fast, as I mentioned, and just in many centers, it as a single organ, largest presentation of malignancy in many cancer registries, apart from being the foremost cause of cancer mortality in the Indian males. Tuberculosis is on the rise, with multi-drug resistant tuberculosis raising its ugly head, so lung surgery becomes much more important. And 3 times as many patients as lung cancer are seen in the chest. Now, why exactly do we really get into a problem with poor results that what we have? If you really see a stage 1 lung cancer, now fortunately they have started dividing it into T1A, B, C, saying from 1 centimeter, 2 centimeter, 3 centimeter. Just 10 years back, when you would see a T1, N0, M0 survival in India, vis-a-vis the survival in Japan, our survivals would be 60% and their survivals would be 93%. The reason was most of our stage 1 were 3 centimeters. We had to beat them down to fit into the 3 centimeter size. So there was a late presentation. The reason is the common symptoms took them somewhere else, not necessarily to a common surgeon. So you have a cough, you go to a pulmonologist. You have a change in voice, you go to an ENT surgeon, so on and so forth. There are attitudinal problems. If a patient comes to a pulmonologist with a lung lesion, which is not very classical, he would treat the patient with anti-tuberculous line of treatment for a few months before he realizes what he's dealing with and then hand over the patient. Lack of awareness itself, that people would not realize that what they are dealing is a very lethal kind of a disease, particularly if the symptoms are not very severe. Logistic problems, that is, the patient may not be able to reach the proper center because of distance, because of monetary problems, and so on and so forth. There could be fear, ignorance, or superstition. And of course, finally, Sahab paisa nahi hai. So this would be actually a reason for late presentation. Manpower, again, we will take it up because what is happening is when you do a lung surgery, it is not only the surgeon who is important. It is also the supportive staff. If a nurse goofs up, your results are not going to be as good. The strength of a chain is equal to the weakest link of the chain. A good ICU is absolutely necessary. You have to be able to rely on your ICU people for a bronchoscopy, for a tracheostomy, for the ventilation pressures, the CPAP, the BiPAP, the minimum pressures, etc. Physiotherapists are equally important. Pulmonologists have to take the baton forward. So it's extremely important to realize that every person is very important. Affordability, it's a long drawn surgery, needs blood, staplers, clips, endoscopic equipment, robots, sometimes very, very expensive as compared to any other branch of surgery. The training opportunities, till I think a few years back, there were only 2 or 3 DNB thoracic courses. There were no MCH thoracic courses at all. Even today, if you really see post-graduation in thoracic means there is cardiothoracic people. And the cardiac part is always more attractive for a cardiothoracic postgraduate. So social issues is, oh, how can you operate a lung cancer? It can't be cured. Why operate it at all? And finally, there are hospital systems. So these are all the challenges. So let's visit them one by one. The desired doctor population ratio of 1:1,000 is not yet reached fully by India, but we are very much in line with that because of the medical college, almost 479 medical colleges with nearly 70,000 MBBS graduates coming out every year. Hopefully, in a few years, we would actually reach this unless our population growth overtakes that. But there is a skewed distribution among states. I'll just show you how exactly it happens. And whenever you go for your MCH cardiothoracic, there is hardly any stress over thoracic surgery. I mean, we would get at Tata Memorial Hospital or wherever, people coming in out of 3 years, they would come there for maybe 1 month, maybe 2 months for thoracic training. That is not really adequate. This is very, very important. And there are practically no or very few dedicated thoracic surgery training centers in the entire country with 138 crore population today. So anybody who wants to go into thoracic will certainly have an anxiety opting for that career prospect. So look at this. Actually, you will find that Sikkim has got the best doctor population ratio, the best one. And then it is West Bengal, Karnataka, Goa, and so on and so forth. But more than 50% of our country doesn't really have adequate number of doctors. Affordability, which is abysmally low, 2.2 to 4% of GDP spent on healthcare, doesn't really speak very high of our healthcare spend and overall. Over 60% of healthcare spending is still on individual saving. So when you say that in a malignancy, breast cancer may take 2 to 4 lakhs of rupees for surgical treatment, the same thing as far as lung cancer is concerned will easily double up. With the 5 to 10% incidence of complications, even in the best of the hands, raises costs humongously. That 7-8 lakhs rupees can become 25 lakhs in no time. And then there are other options, the video assisted thoracoscopy surgery can actually cost because of the staplers, etc. And patients lose out on technology like VATS due to increased cost issues, and particularly the robotic option, etc. Then training is, in fact, it's so challenging that many of these cardiothoracic MCH positions have actually gone unfilled in the last few years because there's too much of grunge work, too much of the leg work, too much of waiting time, too few opportunities for these people. And then at the end of it, you may work, if somebody comes with Harit today and gets trained for 3 years, he should have an ability to give them an MCH degree, which actually entitles them for consultant's post elsewhere. That is going to be very difficult as it stands today. The length of training is very difficult. The training paradigms are not very, very clear. And one more thing is there is extreme hierarchical nature of most practice positions. This is very, very important. We are still almost into a European structure, unlike an American structure, where people can rise to positions in a much earlier age. We all have had to wait till our late 40s, early 50s to become head of the departments. Now, please understand, head of department, it is not like it's not like a temple where older a stone, the more worshipped it is. It should not be like that. You are able to deliver, you have the knowledge, you have the capacity, you have been certified by people. I think you should be able to take a particular position. Secondly, what is happening is today what happened to the United States in the 1980s, where the insurance companies started dictating terms. It came to such a time that a consulting fee was $3 for an antenatal checkup for a patient. So it was no more very interesting for people to get into obstetrics and gynecology. And the same thing is happening to these hard, challenging kind of surgical lines. So there's a tremendously reduced remuneration per case, secondary to proliferation of public health schemes. Now, cancer lung treatment in our health scheme of the national health scheme, well, 23,000 rupees, do a lobectomy, including your staplers. I mean, how do you really fit into that? There are social issues like social stigma is still attached to both tuberculosis as well as cancer. Often families actually request that Dr. Saab, inko aap nahi bataiye ki inko cancer hai. So we still are very afraid to accept the truth of diagnosis, the truth. We keep on being proud of an Indian heritage, Hindu culture, as what we call it as, that we accept everything that is there. We don't really accept things the way a Western population. If you give them a diagnosis, his next question is, doc, how long do I have to live? So that is the kind of a thing which is there. So this needs a certain amount of
you have
environment.
just 2 minutes with you now.
So there are hospital systems. India lags behind through EMR is slowly gaining ground. There's loss of valuable data, and real tumor boards are very important. But wherever you have a problem, you have a solution. So tremendous opportunity to increase both qualification and performance of allied health workers, etc. are there. Increased compensation, along with thoracic surgeon, concentration on allied and important branches can be done. We have 220 national cancer grid centers. They can actually become training centers. Opportunities for innovation with worldwide applications can come in. Techniques to minimize stapler use can be done. Reusing disposable instruments, standardization needs to be done. Development of low-cost instruments. Can we develop a robo at a low cost? Okay, draw on the power of CSR funds at every center. So the paradigm change is going to come from training opportunities. Improve the natural exposure of everybody. Even schools showing the excellent result that surgery can achieve. Evolve mentorship programs. Try and develop training programs at every step. We need to have good thoracic oncosurgeons. We train them first in thoracic surgery. Have regular CMEs. Improve the social factors. Increase awareness that yes, cancer of the lung can be treated. If a screening is done, we can actually catch more number of patients in early stage, and increased efforts for health insurance by the government. Make the vehicle strong. The hospital systems need to be strengthened. EMR and data collection to show the exact status of our results. National Cancer Registry is already there, needs to be reinforced. Digital imaging access and PACS. And if it's difficult to have tumor boards in person, like what we are discussing right now, let us have virtual tumor boards that can be implemented. These are the factors. Thank you.